Introduce the next speaker, Dr. Praveen Sen from India, who's going to talk to us about multimodal imaging and AMD. So, also a little bit related to the previous speaker as well with the multimodal imaging. So, thank you.
Can I have my slides, please? Yeah, thank you. So I thank the APAO and AIOS for this excellent session and the few talks that I've heard till now. I think all women, we must congratulate. They are the best in their field amongst ophthalmologists, and not only just women in ophthalmology. So without any further delay in time, I will talk about age-related macular degeneration and how imaging and multimodal imaging has brought a sea change in not only how we treat our patients, but how also we understand this disease. So AMD, as we knew it, this is what we always grew up with. This is the AREDS classification of early AMD, which is characterized by drusen and RP abnormalities. Intermediate, if the drusen size is more, and late and advanced, the only thing we knew was wet AMD with a CNV or a dry AMD with geographical atrophy. But now, there are almost 38 different types of drusen which are described, and they can coexist in a single patient. There can be small size, large size, reticular, cuticle, hard drusen, soft drusen, distinct, indistinct. And out of these different types, the one which stands out is the subretinal drusenoid deposits, or the SDD, and they are no longer known to be only sub-RPE, but they sit on the RPE, and they have a whole different kind of disease pathology. They are more associated with thin choroids, more associated with older age group, more associated with type 3 MNV, and more associated with geographical atrophy. So this just the kind of drusen, and you have the whole way that we treat our patients can be different. And they can coexist with two different types of drusen. So this is what I spoke about, MNV, which is found to be a type 3 or a RAP lesion, which is more common in patients who have SDD. And so we know that the progression of disease, this was the basic AREDS model, that first you will have soft drusen, and then they cause focal hyperpigmentation, and then they grow into either a CNV or a geographical atrophy. But now we know that you may have soft drusen, and they can be large or intermediate, or they could be SDD. They grow into focal hyperpigmentation, but they can progress to GA or neovascularization without going into RP atrophy changes. And we also have another thing called the pachydrusen, which are large drusen which can be associated with thick choroid and associated with polypoidal choroidal vasculopathy, which forms almost 50 to 60% of our patients in the Asian population. So new classification system, the Conan classification understands that these are no longer always choroidal in origin. These new vascularizations can have macular origin, so especially the type 3 one. So we no longer call them choroidal neovascular membranes, we call them macular neovascularization. So the terminology itself has changed. It is MNV and not CNV anymore. So this is just to show how the type 1, which is sub-RPE, type 2, which goes beyond the RPE, and the type 3, which actually originates in the inner retina and then grows downward. And the hypothesis for this kind of retinal neovascularization is also understood from the imaging modalities, and which is that we know now that these are the short ciliary processes which intersect at the macula and cause an ischemic area there. And because of this ischemic area, which is more so present in temporal to fovea, there is a watershed zone, and this ischemia is responsible for retinal neovascularization, which sets in leading to type 3 MNV. So this is what the hypothesis for type 3 MNV is: aging, thin choroid, hypoxic area, increase in HIF, increase in VEGF, and this VEGF concentration in type 3 MNV is higher as compared to type 1 and type 2, and which is why probably type 3 MNV, if you diagnose, the clinical implication is that they respond very well to anti-VEGF therapy. And these hypoxic areas are very well imaged as well by choriocapillaries flow deficits, and they are related to risk of progression to geographic AMD, and they increase by about 11% if you see, and more of this CCFT is present surrounding CNV areas rather than dry AMD also. not only this, it has been shown that it is the rod cells which are more responsible for hypoxia, and so you may have associated night vision problems in patients with type 3 MNB. So now, where the new vascularization is concerned, there's a sea change, and there's a sea change where geographic atrophy is also concerned. We have always seen geographic atrophy based on fundus autofluorescence, but OCT has been the game changer, where we have recognized that you can have geographic atrophy without involving the RPE. So you have a full thickness or a complete or C-RORA where both RPE and outer retinal atrophy is there, or RORA where only the outer retinal atrophy is there. And this has been shown now in the CAMS classification atrophy report 3. You can see it is divided into 4 types: the C-RORA, the I-RORA, the C-ORA and I-ORA, depending upon whether the RPE or both the RPE and outer retina is involved in the atrophy. And the risk factors are also seen, which is very clearly we can prognosticate these patients, we can tell them how soon your progression can be. So because of the change in nomenclature, we now understand that PCV is type 1 neovascularization, and we call it the polypoidal lesion as well as the BNN, and we don't need to rely upon ICG at all for diagnosing PCV, because now OCT is being used as a gold standard, and there's a major shift to non-invasive form of imaging modalities which can give us the proper diagnosis, and we can treat our patients accordingly. So this is the APOIS PCV work group, which has given us the non-ICGA treatment criteria, which is the sub-RP, ring-like lesion, sharp-peaked PD, and orange nodule. And this put together can help you diagnose PCV with a specificity of almost 80 to 90% in our cases. And even you can treat it, you can map the area on in fast OCT picture, and you need not have ICG to give you the GLD for doing PDT. So definite shift to non-invasive imaging treatment investigation modalities, and also this picture. So what we have also always known that pachychoroid is responsible for the whole spectrum of PCV as well as CSE. Now we know that it is the peripheral vortex congestion which must be the root cause for all this. For all you know, what we have now been treating medically may end up having a surgical cause, and if we sort of decongest the vortex veins, maybe that may give us the answer. So anastomosis between the superior and inferior vena cava, inferior vortex veins is known to be present in 90% of pachychoroid disease spectrum cases, and if this is the horizontal meridian which is involved in the anastomosis, this gives rise to PCV and CSE, while if it is a vertical meridian, it gives rise to peripapillary pachychoroid spectrum. So how does MMI help you in the decision making and management? First of all, it helps you diagnose whether it is AMD at all. There are other lesions in the fovea like a yellow spot or a vitelliform lesion. This may mimic AMD, but this is not really AMD. This is nothing but adult onset vitelliform disease. You can have these vitelliform deposits in patients with AMD as well, but a keen look at the OCT will show you that there is no associated subretinal fluid or IRC, so these can be safely watched. So to determine whether the disease activity is present at baseline and how would you follow up these patients, we have all sorts of fluids. This was not possible before, but now we can compartmentalize the fluid into intraretinal, subretinal, sub-RP, and when to start treatment. We all know that you could have now non-exudative CNV as well. So if you see a CNV which is present but there is no associated fluid, you can watch this safely and follow it up by excellent multimodal imaging techniques, including OCT angiogram, which can show you that even if there is a small increase in the size of this network, you can measure it and gauge it and start treatment accordingly. So this is how you can follow up these kind of cases. You can classify them, as I described, into types of neovascularization. This is important because the response of therapy to a type 2 MNV would be different from that in type 1. As I said, the type 3 responds very well, type 2 will respond well to anti-VEGF, type 1 will need multiple injections. So you can prognosticate cases, you can explain to your patient based upon this kind of OCT angiogram findings. So assessing response, for assessment whether your therapy is working or not, we again have these criteria, OCT biomarkers, which can tell you whether there is a decrease in fluid, decrease in cyst, decrease in height of PED, decrease in the sub-RPE hyperreflectivity or hyperreflectivity. All these things help you gauge whether your treatment is working or not. And when to stop treatment, again, $1 million question. This can also be based on your exit therapy, can be based on OCT and OCT angio. You could give specifically if you have extended the treatment for nearly 16 weeks for 3 consecutive times. If you can consider exit, you can very closely follow these patients on multimodal technique and give them a treatment pause. So imaging in AMD can see more than what meets your eye or my eye, and imaging can be like your best friend holding your hand throughout the journey of treatment for our patients. And with AI, imaging can become much more powerful than we know it today. But I think I would like to still finish. It's just like fire, good slave, but a bad master. Key is always clinical correlation, and there is no substitute for clinical acumen for our patients. So thank you very much for the patient hearing.